Good evening, everybody. It is a very honor to myself to introduce the three eminent speaker and the eminent moderator. I will introduce Dr. Khalil Allah Shibli. He is going to be the chair of this session tonight. Dr. Khalil Shibli is graduated from College of the Anesthesia in UK, and he got a degree, master degree from Maastricht, and he finished his training according to the UK standard. Currently, he is a senior consultant anesthesiologist and pain medicine and ICU and the perioperative medicine Hamad Medical Corporation in Doha, Qatar. Is not only that, he is associate section head of the anesthesiology department in Wakra Hospital. He is the site director of International Anesthesia Residency Training Program in Al Wakra Hospital. He's a member of the co-faculty and the Clinical Competency Committee in Anesthesiology Residency Program in Hamad Medical Corporation in Qatar. He's a member of Research and Audit Committee in Hamad Medical Corporation and Anesthesiology in Qatar. Dr. Khalil Shibli, we have an honor to have him tonight, and I will leave the session for his chairmanship. And just remember, all the action tonight is absolutely in English language. If you wanted to have any comment or any question, directed to Khalil Shibli, Dr. Khalil Shibli, and he will take the question and to the each speaker after each session. All yours, Dr. Khalil. Thank you very much.
Thank you. Thank you very much, Dr. Saad. All the speakers and the participants, hopefully you can hear me. And first of all, I'd like to thank Dr. Saad, yourself, and Mega Medical Association for inviting us as a group from Qatar and present some of the knowledge or share some of the knowledge. So some housekeeping points for the audience and for the participants, please, that kindly keep your mics muted during the presentations. And they can write, they can do chat, they can write question and answer sessions. And I will present one by one our speakers, eminent speakers, experts from Qatar. In fact, in the region, really, if I may say so. So I'm going to move on to Dr. Yasser Reda. Dr. Yasser Reda, can I see you? Yes, can you bring your slides? But I'm going to go through your introduction to, I know you are a very well-known speaker on the international circuit, Yasser Reda. And I'm not saying because you guys are all my friends, but I just want to take our audience through some of your achievements. You are a senior consultant, so that's not a big deal, I'm sure, in your life. You are head of the PACU, which is a post-operative anesthesia care unit and intervention rooms for regional anesthesia and chronic pain interventions at the Hamad General Hospital, HMC. You are the course director of Ultrasound-guided Regional Anesthesia and Pain. You had a good background from studying from anesthesia and chronic pain management at National Cancer Institute, Cairo University in Egypt. You received Doctor of Anesthesia in Pain Management 2001 there. You are Arab board passed. You are a European Diploma of Anesthesia. You have a European Diploma of Regional Anesthesia and Acute Pain, EDRA from Spain. You have European Diploma of Pain Medicine, Dublin, certification of intervention pain, sonography, CIPS, USA. You have a fellowship of intervention pain practice, FIPP. USA, you have ASRA pain and MSK ultrasound certification, ozone therapy diploma, American Board of Headache, USA. And you published many papers and you delivered several lectures. In fact, a lot of lectures I saw recently during the COVID when the lectures have gone online, that you appeared in so many presentations and you're a speaker and a faculty in many local and international conferences. We all know in chronic pain, difficult airway workshops, regional anesthesia. And I can vouch for your skills actually, which we have witnessed and we are witnessing every day with our patients. So Dr. Yasser Reda, your topic, chosen topic is erector spinae plane block, a novel block. So take it away, please. Thank you very much.
Thank you, Dr. Khalil. You heard me and you see my slide?
I can hear you and I can see your slides. And
thank you, Dr. Khalil, for this kind introduction. On behalf of Mega Online Academy, I would like to thank or welcome everyone today, and a special thank for the organizers, special Dr. Saad. In the past 15 or 10 or 5 years, no one can predict what happened in regional anesthesia and pain medicine in relation to ultrasound. When I started my residency in anesthesia, I did the first epidural block after 3 weeks. And it was a very interesting thing. I put it in few minutes. And it was a very difficult patient. It was an easy procedure. And my senior at that time told me a wisdom. It is a blind technique. And this is a beginner's luck. Don't be happy like this, because I can't sleep that day. So after that, many cases I can do.
You can't sleep that night with happiness or with
for happiness. I make the first epidural after 3 weeks, and it was very easy, as written in the book, you know. But after that, I can't put any epidural. It was difficult, and I was dreaming one day. I would put my eyes on the tip of the needle to see the structure, the tissue, not just to feel. But now my dream is less what happened now, less than what happened now. Because ultrasound technique invaded our specialty as non-invasive, portable, no radiation, and the most important fact, you can see what's behind. You can see what's behind the tissue without an opening. You can see what's behind the door without an opening the door. So an era of ultrasound came to change our life about anesthesia and pain. And the ultrasound-guided regional anesthesia, not just guided regional anesthesia as a nerve block, but it may be fascial pain block, vascular or prevascular block, and also the chronic pain. And the most new technique spread like a fire in a world. When just what happened was Mauricio Ferreiro in 2016 is the Erector spinae plane block. So, and every day I found more studies, more review articles, more comparative studies about Erector spinae plane block. And for me, I use it in many things, even not written in the literature, and it works because it comes like this and like a case series or case report. This is my beautiful city, and I hope everyone to visit it, Russell Bar and Damietta. I don't have any conflict of interest, or I don't have anything to declare about my lecture. So my outline for my lecture is first is an introduction, and why the block is novel, functional anatomy, mechanism of action, ultrasound technique and the image. How can you see the image and the ultrasound technique? Indication, contraindication, complication, question to be answered, and home message. But while I'm just giving this lecture, I know that I'm not updated because I update until today, but I don't know what happened from the morning up till now in this Erector spinae plane block. So we all agree that pain is subjective and usually underestimated and being underrated. And this is a monkey over the shoulder of the man. This is an example of Dr. Khalil Shibli. He said that the pain like a monkey on your shoulder, and the pain all the time want to push this monkey from his shoulder to your shoulder. So usually we don't want to get rid of this monkey. And I ask you a question: what is the what is the prevention? How can you prevent the postoperative pain? What is the most effective method to prevent the pain? Don't tell me that not to do operation, because it's a silly answer. So our introduction about regional anesthesia for Erector spinae plane block, a new technique. We must speak a little about ultrasound. Why ultrasound? I tell you that portable, but the most important thing for ultrasound, you can see what's inside the earth without digging, and what's behind the door without opening. And this is a very good achievement. But the problem is they need more skills and more training, not an easy thing. I need a special setting, and you need a professional training like a bars technique, pressure alignment, rotation, tilting, sliding. It's like a professional photographer. And you must know that there is a great difference between the anatomy and the sonoanatomy. Sonoanatomy is like a negative picture of the movie, of the film. So this is, if you look for me, this is my picture as anatomy, but this is my picture as sonoanatomy. So must you know me first to know my sonoanatomy. What about the anatomical variation? You know what, the anatomy we study in the university was not unclear as an anatomy, because most of the anatomy we study is about 70% of the case. And you will surprise and get shocked when you know that Gray's Anatomy, the Bible of anatomy, is done only for dissection of the whole body. And now with ultrasound innovation and vision of our specialty, from 2009, Zimical multicentric many studies about the anatomical variation. In some structure like lateral catheter and lymphocyte is about 50%. And you must know the anatomy and the variation in anatomy. And to look for artifact, because what all you see in the ultrasound is not real. Sometimes real, sometimes you see something and is not found, and sometimes you don't see something and it's found. So take care about that. And you must put a guideline, a special guideline for you to follow all the time, because you are just all the time you play with the shark, and to stop before you block. And this is very important, because in my clinical life, I make a wrong side 2 times in my life. And the surprise, the 2 times work. But it's not a right thing. If you make it's called a wrong mistake and bring a good result, it's not mean, this not means that you are right. And most of the time, you must looking forward to, because you are playing with a shark, you can get a risk and complication. You must be predicting that. And this picture is left one is my grandson, which was born in 2016. But he was looking like a baby from 2019 to 2020. This is a picture of 2020, but he was looking forward, but I don't know what he was looking forward to be the same picture like this 2020 kids. You know, I just speak a little about history, but I just before I want to speak about history, what before history? What's going on? Even I mask this picture because like a human picture, cutting and blood on the everywhere, and this is before anesthesia, and the patient is screaming like you kill him. But you know, you remember all this picture about general anesthesia, but the first local anesthesia which is found was cocaine, and this is provided by color. And at the time, cocaine was in everything, even in wine, in drugs, in toothpaste, and everything. Use and cocaine before discovered this is an addictive properties. In 19th century, German surgeon Karl Ludwig, which was the father of infiltration anesthesia, he make what's called now is rectus abdominis block infiltration, and he make his work in 1899 as business operation. And this regional anesthesia, and this died for 1 century. And why it returned back to the life again? Because there is a technique. And look at long-acting local anesthesia. You have a long-acting local anesthesia. You have an additive local anesthesia. Some local anesthesia now, the cerebral can stay for days. And also, there is many challenges for neuroaxial anesthesia, difficulty in contraindication, and many problems associated with neuroaxial anesthesia. There is invasive surgical technique, now microscopic and laparoscopic, more easy, and enhanced pathway, and it's very important. You want to discharge the patient easily. And more use of anticoagulant in every specialty, in vascular and cardiology and everywhere. And the concept of multimodal anesthesia, which became a standard of care now for analgesia. And this happened with the first non-BOP technique is described by Blanco, 2007, and when you make a tap block by ultrasound, and was a great achievement just for this time. And this is open the gate for research about electrospinal plane block. You know, the first drop about this paper about electrospinal plane block, it came from Mauricio Ferreiro in September and October 2016, and making 4 cases, case report. I spoke to him, he's my friend, and he told me that first time have a patient with an metastatic rib, and he don't know what you can do for him. He tried to make a like local infiltration around, and he injected the local anesthesia, and he was surprised. He found the patient after a few minutes, the patient relief, and the pain relief stay 48 hours. And he don't keep silent like this. And the second case he did like this, it not work because he was injecting above the erectrospinae, not below the erectrospinae. And the idea to inject inside this sheath covering or thoracolumbar fascia, which is covering these muscles. And you know, that's the second case, he make it below the erectrospinae, and it worked. Third case, fourth case, in many different, like cancer pain, chronic pain, and even regional anesthesia for thoracic surgery. And he tested after that what happened for the patient, tested the sensory, and looking for MRI, MRI or CT to see what's the distribution of all. This picture from his work. Now I'm speaking about this block because this is considered novel. Why is novel? because it looks like one fit all. You know, it can be used for neck, thoracic, lumbar, even lower limb. And it works with many types of surgery. An easy block, not like a paravertebral or just a neuroaxial. You need a low times of training, and you are protected by bone. And also have low profile side effect. We don't have a major side effect like other procedure happen in literature up till now, but everything can happen. And also it is a raw material for research. I tell you every day, I am beyond what's update for this block, and open a gate for other facial plane block. And the second thing about is this block, it can make a potential block for the visceral pain, not just a somatic pain. So it can give more and more analgesia. Many people came to speak about the erectrospinal plane block from 2016 up till now. And this is the most common, highest number of research done for any procedure in anesthesia is erectrospinal plane block. In the first year, 2 years, it was only 100 publication. In the last 2 years up till now, you know, I'm just was looking, but I found more than 600 publication, and this year is not finished yet about this block in various type. And even you can found many people like efficacy of bilateral erectrospinal plane block and for pain. Erectrospinal plane block, relatively new block on horizon with wide spectrum of application, case series. Ultrasound-guided erectrospinal plane block for thoracic and comparison to thoracic paravertebral. It found that the comparable for analgesia like a thoracic paravertebral, but the advantage of this block that it can stay for a long time, and even after 12 hours, 8 to 12 hours, you need a low level of narcotics, and it can give a very long lasting analgesia. The time to make the block is less, and the complication is less. Ultrasound also guided electrospinal plane indication, complication, and effect, and it's a very effective procedure and no major side effect up till now. There is many papers, but it can be used even for cervical. Now there is an cadaver study, but we have also many clinical study, but most of the study is just a small randomized control study or just a case report. I'm not speaking about thoracic paravertebral block or just erectrospinal plane block. It is a cervical, thoracic, lumbar, and this is very interesting. Even it is a case report for lumbar, erectrospinal plane block for some cases, and it's published and give a very good result. But still, as a part of multimodal anesthesia, still we are in the infancy of the research. We can't make a solid comment about the erectrospinal plane block. So this is also many studies. Every day I found many studies. Even I was doing lecture, I found and beyond this, it can be used for laparoscopic surgery, for pediatric, for cancer surgery, for many surgery. And this is how the publication run. As I told you, it is about now more than I wrote about 500, but become 600 now. So it looks like in the future it will be like one fit all. And it's very interesting thing, because I can use a very big array of diseases. What about the anatomy of the muscle? You know, this is a picture of Mauricio Ferrero, who makes the first one. This is not an, he doing two things in his life. He do medicine and erectrospinal, and interesting about this. And he don't expect to get this show about what happened, because it's discovered by chance. And I was speaking with him, and this is picture. This is anatomy, not an anatomy of a picture from the internet. So erectrospinal plane block, it is not just a muscle. It is a group of muscle, mainly three muscle: iliocostalis, more lateral, longissimus in the middle, and the spinalis muscle. And they have a character. They attach from the nuchal line for the head till the sacrum down, and they attach from transverse process to spinous process, and sometimes going to the ribs. And the character of this muscle, or just the function of this muscle, to stabilize, from the name, stabilizing the spine. And this is an anatomy of the muscle covered, because this is the nearest muscle to deep muscle here. But in lumbar area, it is a superficial muscle. As I told you, longissimus musculi, iliocostalis. In head and neck, you know, they added some muscle more to have the same function and related to the spine, like splenius capitis and longissimus musculi muscles. So the mechanism of nerve block, what happened? What is the mechanism of nerve block? You know, the local anesthesia, when infiltrated, it distributed in cephalocaudal level. It can go up a few level, down few level. There is the diversity about the study. It can go more from 0 to 9 level up. But you know, we need more study to show the distribution. It blocked the dorsal rami and what's called an ventral rami at the same time, and this distribution for paravertebral space or even some basilic chain, even to go the other side of the nerve. And also just going with intercostal nerve if you make it for the thoracic. And the distribution may be an place specific and volume specific. So this is a very this picture showing the anatomy. This is the spinous process, erectorospinae, and this is the transverse process. This is the erectorospinae muscle. The description to inject on the tip of the erectorospinae, and this fluid distributed here to go for this area, which is the foramen and nerve and sympathetic chain. This is the mechanism, and this is how to do it. Just injected above the transverse process. And the anatomy trapezius rhomboid. This is an above T5, trapezius rhomboid and erectorospinae to inject above the transverse rib complex. And this is a study from cadaver study, injecting methylene below and look for the distribution. This is an CT study, 3D study to show the distribution, how it works. And this is another picture. This is how when you make it for upper thoracic, what is the distribution? Also CT, and this is another study. This is a cervical erectorospinae block cadaver study and showing that the distribution go until C3. And here also a cadaver study when injecting methylene below to go for the sympathetic chain and going to the epidural through the foramen, and all this area becomes stained by methylene below. And here to show that the difference between retrolaminar and erector, that's an retrolaminar block or just lateral block. And here this is a MRI with gadolinium. You can see when I injected erector spine here with gadolinium, you can see the fluids, my fluids just going to the nerve root, epidural, and the other side, but the concentration and volume is not enough to make a complete epidural block. And this was 7-star needle when you go in endoscopy to see what is the distribution of your methylene blue. There's another picture about how it works. This side is an retrolaminar, and this side is erectorospinae, and erectorospinae is more effective and more distributed than retrolaminar shown by study. Another picture, this is how to show it. Another picture about it. And this is normal, this is to go on by with the nature. This is a space and the fluid found that track. This is a nature. And this picture is not me. So, you know the indication, neck and shoulder pain, everything. You can indicate it for everything. Chest, breast, rib fracture, video-assisted surgery, abdominal surgery, even lower limb surgery, lumbar erectorospinae, sacral erectorospinae can be used in many things. And also the other indication like chronic pain, neuropathic pain, spinal cord injury. I have many case reports. Myofascial pain syndrome. I don't inject many times like before. Just I don't look for the tooth band. I just inject erectorospinae. It works for all this side. Chronic shoulder pain. Some cases of Feldbeck surgery syndrome and facet pain syndrome. Many times you can use it for musculoskeletal spasm and musculoskeletal pain syndrome. Contraindication, like any other block for regional anesthesia, lack of training and hospital facilities is very important. If you don't do it, if you can't do it, don't do it. Patient refusal, severe coagulopathy, but it can done for, you know, that to have a liberal coagulopathy, not like an epidural. It can be done in INR a little higher than the epidural or spinal. As indication, infection at the site, you can't make anything. This is like a normal. And distorted anatomy, if you don't have anatomy in this area, and cancer through the area of injection, and allergy or any problem to the medication before. Complication is still up till now. We don't have a severe case report about severe complication, but infection and bleeding can happen. Allergic reaction can happen with the medication. Intravascular intraurethral injection and causing a nerve injury of toxicity. Visceral and thoracic structure and not recorded up till now injury. Abdominal injury and the failure of the block. And also the most important is a high volume block. It can make an local anesthesia systemic toxicity. And you must know that you are some complications is devastating and you are below the sharp. Take care, don't do it, except if you are trained to do it. Equipment, and you know that we can't make it in any place. It's an operation. It needs a special setting, a special preparation all the time. And we can make it by sitting lateral prone position. Usually I use prone for education more better, and because usually I use our patients is heavy, use a curved one. I need a heavy one, especially if you have a resident trainee. But we can make it in a position. Also, the local anesthesia spreading up and down. You can check your spread about the local anesthesia. Scanning technique, you know, the original technique to scan parasagittal and to go from up and down, but you can go from down and up if you have professional enough, if you see your needle. It is about 2 centimeters from the midline, but the trick here to make it on the tip of transverse process. And parasagittal scanning, sometimes you don't know the tip. So you go for the rep and just go medial until you see first area to see the transverse process. This is the tip, and this is the most effective technique. You know that you must know from the anatomy that above T5 only trapezius, rhomboid, and major, and the erector spinae below it. But below that, you don't find this rhomboid major. And here, this is like to see what's going on when you inject it on the tip. Here, you can see your distribution of the fluids. This is also just a picture I want to compare between paravertebral and the erector spine is more easier, and this is what's called the Neptune trident sign, just this frog of Neptune. And here also to show the difference between pictures. This is like a lamina. When you see two appearance lamina, here you can see the transverse process because the pleura is a little far away. But with rib, when you see the rib is a little more flat and superficial, and you can see the pleura is very near. And this is the anatomical picture, trapezius, rhomboid, and this also the ultrasound. As I tell you, the ultrasound is a little different from the anatomy. And this is another picture when you see the transverse process. This is a muscle, the plane to inject here above the transverse process to separate the transverse process from the erector spinae, and the fluid going to this plane. And this is a very interesting picture here, the erector spinae muscle and this transverse process. This is what's called mid-transverse block, and not effective like erector spinae or paravertebral here, superior costal transverse ligament. You know, so the aim of argument or discussion in everything should be not be the victory, but progress. It's very important. But there is many questions to be answered up till now. We don't have the answer to this question. What's the optimal dose? Concentration of local anesthesia. We don't know. It is a high volume, low concentration. There is many debate about that. There is also this one with basis. It shows a dose for per kg. This used for the block for analgesia and needed for conjunctive was anesthesia. And also here, just I'm telling you a little thing about my practice, and I collected this one. It is like a paravertebral from 3 to 5 ml per segment. So look for the segment, and 3 to 5 ml is a sufficient amount for the block. Usually I make an 4 ml per segment. Second thing, you must see the distribution type, single or versus level of multiple level. Most of the study was doing on single level, and it worked. The most important is distribution, not a multiple or single level. But Tulger from Turkey report 2 level of erector spinae block were performed and said it give deeper block. And this is just a case report. And the interesting thing about erector spinae block, about 25% of the research came from Turkey. And from Japan and Canada, the original place for block, it was about 32% of this research. So another question about erector spinae, what's the optimal approach? Parasagittal, transverse, out of plane, in plane, oblique. This, I like this technique. I created this technique, and easy for me because this is the same technique for selective facet nerve block for the thorax, and also costo-transverse joint injection. Also above or below erector spinae, most of the research are now below erector spinae because above erector spinae sometimes not working. So what is the evidence about this block? And they must know that the absence of evidence is not evidence of absence, because the absence of evidence may be because of lacking of the more study, you know. So now you can see many study about that. This study erector spinae as a novel block, where have erector spinae should be considered an alternative analgesic option for patient with acute and chronic pain and trial. Another study, Erectospinal balloon block is possible for analgesia effect may be limit opioid consumption and cesarean section, even cesarean section. Ultrasound-guided spinal block versus intercostal block, more superior to intercostal block and long-lasting and less complication. Ultrasound erectospinal balloon block versus this is for surgery for plastic surgery and more effective and more long-lasting than injecting the local anesthesia with lidocaine with fluids for plastic surgery. Also here, comparison erectospinal balloon block with thoracic paravertebral block. You know that we found that the analgesic effect of erectospinal was equivalent to thoracic paravertebral block after thoracic surgery with lower local anesthesia blood level and also with less complication. Again, because sometimes the logic, not all the logic is sign and not the sign is logic. Erectospinal balloon block versus paravertebral nerve block for both of the analgesia of breast surgery. You know that the same. The erectospinal balloon block as paravertebral block, but erectospinal can save a long time and less complication and short time just to make the block. Again, many study. You can look more many study. You know that Mirasio sent me about 72 randomized control study, but you can tell me this is not a big scale randomized control study. Yes, and some case report, but everything started like this. And this a case report from Saudi, just published in Saudi Journal of Anesthesia about cervical paravertebral bilateral cervical paravertebral erectospinal block for spine surgery, just fixation of the spine, and that it was a very good without any narcotics, and post-operatively it was a very fantastic result about the analgesia and give a very little amount of narcotics. But still, you can tell me then, and also the comparison between quadratus lumborum and the erectospinal balloon block. Erectospinal is more effective and give a long-lasting and less complication. Also in pediatric, erectospinal and transverse abdominal spinal block, erectospinal more effective. It may come from this and paravertebral and just going to give and more analgesia. Many study. You can just look at study. Even now, I found 2 or 3 study about sacral erectospinal in vaginismus and fracture and very effective in fracture sacrum and sacrococcygeal joint pain or just coccydynia. Also, there is many study. You know that all this study I got it from Mirasio, and they sent me about 72 randomized control study, and even just in renal colic in as well study, and it's a very interesting study about anesthesia between paravertebral and erectospinal balloon block for breast surgery, and they provide similar post-operative pain effect, but some people just still argue about. Many studies showing that about the paravertebral more better, and many studies if you look for all this study. But at the end, I come to the during disclosure. This Karmakar, he write a letter, editorial letter that this erectospinal is just a show, and it will end like an like other block which came to the surface and flourish and stop after that. And he compared between this one and the intra-broa block, but this comparison is a very bad comparison. And also when I read the editorial letter, I found like an journal report and do not have any scientific evidence. And I speak with Mirasio and just now, and this is our message from Facebook, and he told me that I write also editorial letter arguing with this with people, and this letter will come soon. Just I speak with him yesterday until soon, inshallah, after accepting this letter about the erectospinal balloon block. And you know that the doctor is a student till his death. When he failed to be a student, he will die. And this is Osler from Canada. And I know the time is squeezing, and they permit me only 30 minutes. So I just will tell you what's in you. This is just what I use it in my practice. Sacral electrospinal balloon block and vaginal dilatation for vaginismus, and this study comes from Turkey and very effective in 13 over 17 patients, and 11 of this patient get pregnant after sexual intercourse. Electrospinal, this is a very new paper in this month with renal colic versus non-steroidal anti-inflammatory, and it's very effective, more than non-steroidal. Sacral epidural erectospinal balloon block and transgender surgery. We don't do this surgery in our country, but it works in all genital surgery. It works in a very good way. Sacral erectospinal balloon block for fracture sacrum and the sacrococcygeal joint pain. Lumbar erectospinal block for field back surgery, it works in some cases. Lumbar and cervical erectospinal block and facet pain, it works in some cases. My experience in our institute about this erectospinal and what I see in my patient, but just it is not coming to be under mass control study, just a case report. My official pain syndrome, now I inject one injection instead to look for tooth band and to inject about 6 injections to get a hematoma of the back. Field back and neck surgery, if very complicated and you do everything and not work, just to try erector spine. Spinal cord injury, I have many cases about spinal cord injury and girdle pain and improved. Both herpetic neuralgia, and this is well known and they have been studied now. Complex regional pain syndrome, we have a study about in upper limb, and I do for one of the lower limb and it worked. Chronic post-surgical pain, thoracic facet cervical pain, shoulder pain syndrome, in many cases, especially if included the muscle of the neck and shoulder. Other musculoskeletal pain and spasm, lumbar nerve block and facet block, it can be, because there is a technique, it's called the pararadicular odysseus, described by Samir Narouz in his book about the Tumican by ultrasound. And all the case report, so we need a more randomized control study. This is a very important thing. And this is my technique, how an oblique technique, this transverse process, and this is a rib. And if I go here, I go with the tip, I see the tip, but transverse sagittal, parasagittal technique, you don't see the tip. So I see the tip, I can enter this area, this is the erectospinal muscle, and inject the fluids, and I rotate the probe to be like a parasagittal technique to see the distribution. And here at the same time, this is a joint. Sometimes you get a pain for chronic pain from joint. And also the tip of the transverse process here, the medial nerve of the thoracic segment. Because in lumbar, it is unlike between the lamina and transverse process, but here on the tip. So you can make all this injection by just this view. My home message, I know that time is squeezing. Conclusion, if you work with ultrasound, you must know to study a good study for the anatomy and variation anatomy and to see how can you see this structure by ultrasound. And you must make a complete sitting and safe place because this is an operation. You have many complications can happen. And to know the indication and contraindication, not to harm the patient. Valuable knowledge about the machine, how to use the machine, how to adjust your machine, how to inject your drug, and everything about your drug. And to be ready for complication, not just to treat, just to discover and treat. I know that the problem with the erector spine, it is only the age is 4 years. And, but really I found it is very good in many patients in my practice. And also that every day I found more study, and the randomization become more bigger, multicentric. So the data come, we know that they are in the childhood of study. Data come usually from case report and some more randomized control study. We need a big one. Many questions still to be answered about the block and the technique and dose and all this stuff. Comparison between study more difficult. Sometimes difficult to compare between a study erector spinae and tab block or quadriceps block. Also, if the outcome is not favorable, many people don't publish the result. Also, and again, publishing is only one side of the coin because I don't know the expertise of this researcher. He may be expert and bring a good result. He may be not expert and bring a very bad result. And also, we need, I'm looking forward because I know this blog soon because I use it. It will be one fit all and it's very impressive because we don't have anything one fit all. And we need more studies to prove that in one fit all. So our success to be a right drug, right surgeon, right site, right assistant, right anesthesia, trained and skilled, and right equipment, right environment to be block room or equivalent, right patient and right doses. At the end, if you feel your pain, you are alive, but if you feel the pain of others, you are a human. And I hope next year we don't have a COVID to be kicked out, to get a red card, to be kicked out from our practice and to see you face to face, inshallah. Question and answer. Thank you very much.
Thank you very much. Thank you, Dr. Yasser. But we have some questions, as you were right, we're a little tight on the timings. So I'll go straight to the questions. One question is coming from, let me go back there in the right timing. Yeah, they're mixed up actually. So Dr. Talat, and asking which is preferable for post-operative pain management for breast surgery, PACS 1 and 2 or ESPB you described?
Yeah, there is many study now just showing that erectrospinae more effective because erectrospinae can also block the visceral pain, not just and also more spreading for the center because this is like the same. It can block also erectrospinae can block many nerve, intercostal nerve, even lateral pectoral nerve. So most of the study now showing, but they need more randomized control study. There is many case reports. There is a small randomized control study. Erectrospinae more effective. The more you go to the midline, the more to be effective.
Okay, thank you. Mustafa Risk asked, thank you, Dr. Yasser. Is there a comparative study or are there any comparative studies between ESB, paravertebral, and thoracic epidurals? I believe we meant all of them, inclusive of everything. So,
yeah, there is a study showing that, but this is a comparative study between narcotic use with epidural versus bilateral erectrospinal balloon block with catheter. The comparative study is showing that erectrospinal balloon block may be a replacement for thoracic epidural, the same like an narcotic